Good afternoon and welcome to Coffee with the Commission, a time where the WMC discusses topical issues that affect you. Today we will be discussing the 2025 legislative session and the bills that may impact you. I'm here today with Stephanie Mason and Micah Matthews. Stephanie and Micah are going to give you a review of the 2025 legislative session, and then we will have time for discussion and questions. Feel free to ask your questions along the way by using the chat function at the top of your screen, and we will address those questions after the presentation. Please understand that we cannot discuss open investigations and cases in this forum. Before I turn the webinar over, I would like to take care of a few housekeeping items. We are recording this webinar and it will be available on our website within the next few days. Please feel free to share these resources with your friends and colleagues, and if you have any questions, you can reach out to me. Remember to stay muted unless you are speaking. And if you are having trouble with sound, we find that exiting the meeting and rejoining is the best way to resolve those issues. So with that out of the way, I will turn it over to Stephanie.
Hi there, sorry. I was trying to double check that we had the right presentation up here. We have two versions of this, so you might be getting the one that Micah was leading at the moment, so bear with us. As Jimmy said, my name is Stephanie Mason. I'm the Public Information Officer and Legislative Liaison with the Medical Commission. We do these presentations twice a year at the beginning and the end of the legislative session. We like to share an overview of the key issues we encountered, and a big part of our goal is to explain who we are and how the WMC is involved in the legislative process. The Medical Commission licenses and regulates about 35,000 healthcare practitioners. We're overseen by 21 commissioners appointed by the governor and supported by a staff of 64, including a legislative team of 4, soon to be 5. Our role in the legislation and rulemaking is complex sometimes, but we have a goal of promoting patient safety and protecting the integrity of the medical practice standards, and educational requirements for practitioners. I think Micah had some comments he wanted to say about the PAC.
Sure. So as we noted, we don't have a political action committee, and as the entity of the state, we don't donate any money to any of the legislators or their causes. That doesn't mean that we don't get access and meet with the legislators on a pretty regular basis. A lot of that is dependent on our reputation and what we've worked to cultivate as a reliable organization that can be called upon to bring whatever information or research that the legislators might need to make a policy decision. So that's usually our role, is trying to educate. There have been a couple of scenarios in the recent past where we have had to directly engage and advocate for a change to a bill. The one that comes to mind is the reproductive fraud bill most recently, where it was a good start, but being the regulator, we saw a number of loopholes that should be closed based off of our recent experience. So with that, I would say go ahead to the next one.
During the session, the Medical Commission tracks, monitors, and analyzes bills that come through. We're an independent agency, but we do work collaboratively with the Department of Health. The WMC testifies on bills and meets with legislators, as Micah said. We help educate stakeholders and the public on legislation that's beneficial or detrimental to the practice of medicine. Additionally, the Medical Commission takes part in the rulemaking process. The rules become part of the WAC, the Washington Administrative Code, which is different than state laws and statutes. Oftentimes, rulemaking is included as instruction within legislation that's passed to give some clarity and guardrails to how it can be implemented. As you can see here from the slide, there's a little bit of a definition of how statutes and regulations differ, and then some really simple to read graphs. Obviously, I'm being sarcastic. They're very complicated. If you guys have any questions, our information is on the last slide. This is a broad view of the types of issues that the WMC tracks each session. As we noted a couple times, the commission may testify on one of these concepts, especially though if it's legislation that directly affects our Practice Act, directly requires the medical commission be responsible for enacting some part of the legislation, or could negatively impact the practice of medicine or the public, or puts new responsibilities and mandates on the educational requirements for physicians and all practitioners. Most of them listed here are self-explanatory, but we do find the legislature sometimes attempts to intervene in the practice of medicine, often by attempting to mandate, as I said, education, actions, questioning their professional judgment, and we believe that that should be left to healthcare practitioners in their offices. The last issue here, the budget, was especially impactful this year. The state faced a huge shortfall, and Micah will get into that later. Do you want to add anything to that one, Micah? No. This session saw new leadership at both the state and federal level, as I'm sure you're aware. We were prepared to see an uptick in the number of bills introduced that focused on reproductive and transgender health. However, interestingly, that was not the case. For the medical commission, the most important policy committees are the Healthcare and Wellness, the House Healthcare and Wellness Committee. It has 15 members, and the Senate Health and Long-Term Care Committee, which has 12 members. As you can see, I think it should be on the left of your screen, Senator Annette Cleveland, Representative Dan Vronsky. Help me, Mike.
Bernowski.
He was a very big help in the passage of our UDA text bill. He was new as the chair of House Health this year, and we continued our great relationship with Senator Annette Cleveland, who is the chair of the Senate Health Committee. Also of importance, especially in the bill Micah mentioned earlier, is the Senate Law and Justice Committee, which is chaired by Senator Dingra. This committee was responsible for the passage of our reproductive fraud bill in 2024. On a future slide, I will have a legislative link where you can look up that bill and find all that it contained. And last but never least, the fiscal committees, which you should be able to see to the right, the chairs of those, House Appropriations, which is chaired by Representative Tim Ornsby, and Senate Ways and Means, which is chaired by Senator June Robinson, are also critical committees for us getting our requests in the budget and other funding for our bills. So these are the people we work with in the committees that are most important to us, our leadership. Mike, I don't know if you wanted to talk about the other one, postgraduate. I'm forgetting the name of the committee. We do have another committee which sometimes discusses our compacts.
Yeah, it's the education and workforce, and then post-secondary education and training committees, and those popped up, I believe, starting 2 years ago, as there was a difference, or as there was a reinterpretation of what the House and Senate healthcare committees were going to deal with, and one of those things that they decided they were not going to deal with were health profession compacts. So Washington, if you're not aware, is probably one of the national leaders with respect to adopting the number of compacts that it has. At this point, it seems like Washington has not met a compact that it doesn't like, and that's fine. That's mobility that we're trying to do for healthcare professions, and that has impacts with respect to military members and spouses, and just generally getting people into a friendly practice environment here. So that's all I would have on that.
Yeah, it's not listed here. We didn't have any bills go through that committee this year, but it continues to be important. So last year, here's that link I promised you guys. You should be able to look up and put these numbers right in the front page of this ledge.wa.gov site. Last year, we tracked 63 bills internally and over 100 collaboratively with the Department of Health. We shared just a handful of those on this presentation. This year's legislative session was notably different from the previous year. The The Medical Commission tracked roughly 50 bills, which is a little bit less internally, but then only 10 of those bills made it to the governor's desk. The Department of Health tracked 27 bills, but did an extensive analysis of each bill to equal over 257 bill analysis on those 27 bills. So quite different from previous years. I'm not sure because of the legislative site, which is a little behind this year, is predicting to have stats for the session in June. We normally put up how many bills were introduced. In previous years, the number of bill introductions has been at least over 1,000, sometimes over 2,000. My guess is that there was a significant reduction in bills introduced overall this session. The governor's office significantly limited the number of bills introduced, largely due to the substantial budget deficit. And the Medical Commission, that I speak for the Department of Health probably also, really had to think. Every decision, analysis, and recommendation we made this year was made carefully, knowing it carried very many potential impacts. And to say the least, it was a challenging session. I think Micah is going to give an overview of some of the details of these bills from the 2025 session. And again, if you want to look them up, you can visit the legislate site as we're talking.
Sure. So just a clarification, when we say that we track a bill, that holds for us internally, that holds some significance with respect to how much workload we're actually dealing with. So as staff of the commission, we are responsible not only to be aware and make sure we know what's going on with the bills for our organization's impact, but also we have a responsibility to report out to the commissioners, commission leadership, and that sort of thing. And we do try to coordinate quite a bit with professional associations that have similar concerns and interests. So that'd be the PA Association, the Physician Association, the Hospital Association, as well as and the Anesthesiologist Assistant Association now. So those are all considerations as we go through. So when we say we're tracking a bill, that starts off with we have done a brief analysis when the bill has been introduced, and that's really just to see, is this of an impact to our organization or to the practice of medicine? If that's a yes, then it gets escalated into our tracker. If it's directly impactful to us, we are likely going to do a bill analysis on it, just to better understand all the impacts. And that's where we're getting different folks in who may be impacted. Say there's rules that it looks like that it was required. We're going to talk to our program manager who manages making processes to understand just how much of an impact this will be. Is it going to be simple rulemaking? Is it which is just deleting some language that is no longer applicable? Is it going to be regular rulemaking, which takes about 12 months? Is it going to be contentious, which is 18 months or more? So those sorts of things occur. And so when we say we're tracking a bill, when we say that's an automatic workload assumption for us. So with and while Stephanie did point out we've got a team of 4, soon to be 5, none of those, including myself, is full-time devoted to legislative work. We all have other parts of our jobs. So I mean, with Stephanie, as much as I appreciate her working on legislative stuff, she probably the lion's share of her work is as the public information officer for the Medical Commission. So we focus more during the legislative session, but we don't have anybody full-time dedicated to that. So moving on to the 2025, I will talk about a couple of the bills that we were directly involved with. So the first one is House Bill 1640. That was our request bill. And part of the slowdown that we had in this legislative session is there was a transition between governor administrations. And I think in speaking to folks in the Ferguson administration and the Inslee administration, it was communicated to me that roughly 70%, I believe, of the Inslee staff were leaving. So you can imagine with that much turnover and so many key positions, there was a slowdown of just about every process there is, which is good because we needed to focus as a state on those as previously mentioned budget shortfalls. So the one bill that we got through as agency request was this one, 1640. And what that did was during the adoption of the physician and physician assistant compact, Due to Scrivener's error or something else, the reference in 18-130-040, which lists all of the professions and chapters that are relevant and come under the Uniform Disciplinary Act, those two compacts were not listed. So technically, they were not part of it, part of the UDA, even though there's a lot of legal evidence to suggest they were. We needed to do that technical fix just to clarify that, so we would head off any legal arguments from the future. The next one, it was a medical association priority, which was creating a well-being program for certain healthcare professionals. Think of that as an EAP for physicians, or an employee assistance program for physicians. It's focusing on wellness, addressing proactively maybe mental or physical healthcare concerns. And it's just an escalation from self-management, and it's meant to be a stepping stone from doing nothing to being referred to the physician health program. So it's really that niche that it's trying to fill. We yet again saw with Senate Bill 5632 confidentiality of records and a shield law. So just further trying to prevent folks from outside of this state, as well as actors within the state, from getting certain information. I believe this one was again related to what we call covered services, and that's reproductive health care and gender affirming care. One long-term bill that we've been working on with the work group for international medical graduates was Substitute Senate Bill 5118. That was a part of a trio of bills. That's the only one that was successful. And that amended the requirements for the clinical experience license. So that's a license that's designed for international medical graduates to help them get recency of clinical experience in a setting with at least 3 or more full-time physicians delivering direct patient care. So roughly, the bill removed a 12-month requirement to be a Washington citizen. It removed the requirement for U.S. medical licensing exam step 3, so it aligns with what's called ECFMG certification. And as you go through that, you do an English test and you do transcript verification, school verification, and USMLE steps 1 and 2. So we were trying to align with that. It also extended the renewal possibilities from 1 to 3, so the license is valid for a grand total of 8 years. And as you can see, we were able to get these some pictures of the governor when they were signed. Notably, Senate Bill 5118 was with sponsor there, Senator Valdez. That was the first bill that Governor Ferguson signed ever. So he was very strategic in wanting to make that his first one out the gate. He's very close to Senator Valdez, as they're good friends, and he's actually the senator is actually the representative of the governor in his home district. And I think there was one more, Stephanie, did it on that last slide? Oh, right. EMTALA. That's the fun.
Yeah.
There, for those who follow it, there has been some work on the federal level in the courts about EMTALA, and does it cover certain services? Are there conscientious objections and that sort of thing? And how does it impact state sovereignty in those situations? The Biden administration started the lawsuits on this, trying to make sure that those services like reproductive rights are covered when someone comes in. Their interpretation was, if you're accepting federal money, if you are subject to EMTALA, you must have those basic services if you're going to offer them at all. And so that bill was really trying to codify that you must provide those services if you're subject to EMTALA. So that's a very high level version of that. Next slide, please. So with respect to timeline, just to give everyone an idea of how the medical commission works. So right now, even though the legislative session ended like 3 weeks ago, we are in the thick of identifying potential legislative issues to bring forward for 2026. We are aware that there's going to be less throughput from the governor's office with respect to agency request legislation. They're planning on keeping it pretty limited for at least the next legislative session. I don't know if that's related to workload or anything else, but that's their decision to make, and so we will be subject to that. I point out that we search for non-legislative solutions, and that's simply just a pragmatism thing. If we can do it via rulemaking or policy, we do, and that's just because it's so unpredictable, and there is a bandwidth limitation that happens with trying to put through legislative stuff, and you don't want the conversation with the legislator of, if you can do this via policy or rule, why are we seeing it here? Why are you wasting our time? So that's where we start, and all starting in May, all the way through November, we get feedback from interested parties. We are required to brief our executive committee, which is our chair, vice chair, policy chair, and members at large, and then ex officio, our panel chairs, panel A and B. Those are our disciplinary panels. And so we do brief them on concepts that we are looking to bring forward, not necessarily the language of the bill, because that can change a lot. And this year, based off of meeting schedule, we will work on getting their formal approval in a business meeting in July. At that point, we work on getting commitments of support from associations, interested parties, and informally maybe getting some testing the waters to see what legislator might find something interesting, or might have an interest in trying to sponsor a bill. September is really where the rubber meets the road for us. That's when we have to have all of these formal things that are submitted to OFM. So it has to be either a legislative request, a decision package request. There are many pages that deal with what are we trying to say succinctly, what are the impacts, fiscal, political, what have you. And at that point, it kind of goes into a black hole, and we don't hear anything. I've never been able to figure out if not hearing anything is good or bad. Sometimes you get a ton of questions, sometimes you get a few, but that's just, you're waiting around to respond to that, and that's just part of the process. And then come November, you have committee days. We generally don't jump too much in committee days, because that's where a lot of the groups that have political action committees are really trying to get in and see certain legislators. They're trying to make sure that they're aware, and maybe even gather signatures at that point. And then, of course, you got the workshops and everything. Usually, if there's a work group or workshop, we might be pulled into that for some reason, and that's been fairly consistent in the last couple of years. November, again, we get questions from the Office of Financial Management, and usually, hopefully, we get notice that we can start to that the agency request information was released, and we can go gather signatures at that time. Next slide, please. And I broke these 2 months out just because there's a lot that goes into that, and I was going to talk about the budget process a little bit more just internally, to give folks an idea of how we have to go about things. So December, obviously, we're looking to get included in the governor's budget. That's step one, and that's usually an indicator of success. Being a smaller agency, we don't really rise to the level of a DSHS where we need to have multiple budget requests for multiple divisions or anything like that. Usually ours are quite small, and given the fact that we're fee funded and we're fiscally responsible, those questions are the first out the gate. Do you have the money, and where's it coming from? When we can answer that, that's pretty easy. And so at that point, we're contacting House and fiscal staff and their chairs to make sure that they know that this is coming, and we'll give them usually a fact sheet and meet with them at their request to educate them about the what's and whys and where's the money coming from. And then if this is a piece of request legislation, we would pre-file the bill at that point. And so that would be introduced within the December timeframe, hopefully, as a pre-file, and then introduced on day one. And of course, January legislative session begins, and the governor's budget gets formally introduced. And then I think it's in February, is when the House and Senate budget get introduced. I think the next slide is where we're going to talk about. Yeah, there we go. So just addressing the medical commission's budget. So in 2008, we did get increased specific authority statutorily over staffing and budget. That means that while we work with the department, our budget requests get submitted without any review or approval decision making from the department. It just gets submitted to OFM in the same packet. We do get some technical assistance as needed from the department just to understand where our budget is, what predictions are happening or forecasting what happening. And so we live in we call it the O2G. It's the health professions account with the rest of the health professions who are fee supported. And our funds, they have to be appropriated and allotted for us to spend them. Generally, there are workarounds such as Helms, where we have been able to say any payments for that database upgrade are going to come out of our reserve, and then the folks in the secretary's office handle that. So we call our budget request decision packages. That's because the legislators have to decide whether to fund them. And so there are three generally categories. You've got the maintenance and operations, you've got increased caseloads, which can kind of be considered maintenance and operations, and then you have what are considered new policy or new programs. Notably, expansions can be considered increased caseloads. So one example of that we were successful with this year was adding administrative support to investigations, as well as adding customer service to the licensing group. We've had an increase. When I started, I think we had something like 26,000 licensees. We now have 36,000 and growing at a pretty good clip. So there's just an exponential rolling that happens with those cases and customer service. And so as I said before, we're fee funded. We almost always have a reserve that we're holding according to OFM's requirements, and so we can just ask for a spending authority increase only. We're never we are never asking for money that we don't have. That's another issue, and so we certainly don't get into that. Next slide, please. So the legislative concepts that we're kicking around right now, just for transparency, we did request legislation this time for what's called a non-disciplinary license relinquishment process. So if you are a practitioner and you have a health issue, or you're moving and you don't want to deal with your medical license of Washington anymore, under this bill, you would be able to do a relinquishment. It's not a surrender, it's not reportable. And notably, Washington Physicians Health Program is very much in favor of this option, because right now, legally, in order to completely give up your property right, which is your license, we have to do one of two things. We can either do an agreed order, which is reportable and is considered formal discipline, or you can do what's called a stipulation to informal disposition and agree to surrender your license that way. Again, reportable and looks to the outside like a black mark on your record. And so we're wanting to create a non-punitive, non-reportable process where people can simply give their license and give up their property right without it looking like we took discipline on them. There's a lot of reasons why people want to give up their license, everything from medical to relocation to just retirement. And so that's something that we want to put forward on and hopefully accomplish through the rulemaking process with specific authorization. This is a protection of licensee personal and demographic information. I've been hammering on this for years because if you're collecting information at the state, you have to know what you're going to do with it. And that's just a responsibility piece. And in this current environment, the sunshine aspect of Washington State gets problematic when you introduce bad actors. I think the other piece that we have to consider is the Public Records Act was formed was passed in the 1970s, and it really doesn't account for things like data sets that you can get from illicit sources, large language model processing, AI tools that are now publicly available to compare and combine those data sets and really specifically identify people. We had, even without AI, we had a few years ago where people were able to get what's called CHARS data, and they were able to compare that to billing, and they were able to specifically identify patients who were in hospitals and what procedures they were having. And and unfortunately, the people that identified it were reporters. So the confidentiality piece is a big one, and we're wanting to maybe take a look at that. We've had conversations about creating a locums license. It would be a short-term license for people that need to come in on a 6 months or less basis to be able to provide workforce support, allow for surging and that sort of thing. So the idea would be the standards wouldn't be lower, but the process would be reduced because there would be more oversight at the institutional level. We are also talking about the Uniform Disciplinary Act. That's what covers all of the health professions regulated in that previously mentioned statute 18-130-040. And just some of the things we're talking about is clarification on revocation standards. Right now, there's a legal nuance that some people find entertaining. And basically, there's two revocations, revocation and then permanent revocation. And we want to clarify that revocation is actually permanent. And so by eliminating the other one and just making it clear that you can either be suspended or revoked, and one is permanent, one is not. Some clarification around sexual misconduct and that process. Currently, we transfer those cases that do not seem to involve clinical care to the secretary for processing on sexual misconduct. That transfer and handoff does tend to lead to a little bit of sometimes confusion, as well as we need to clarify exactly what process they would charge on some of these. And then finally, a skills assessment clarification. Right now, we have the ability to send people for assessments. Generally, it's been interpreted to include skills assessment. We have been getting some pushback because it doesn't specifically say that. So you can be assessed for, substance abuse impairment, medical, mental issues, and that sort of thing. It's just been implied that your clinical skills could be assessed, but there's been a request to make it specific, so we don't have to rely on interpretation. And finally, our old chestnut, the medical examiners. The crux of this is the Uniform Disciplinary Act requires, and the Medical Practice Act requires that we license medical examiners who are physicians. Except the Uniform Disciplinary Act assumes that your patients are alive. And that's throughout the entire chapter. It just, the language assumes a live patient. And as we know, it's difficult to argue that a medical examiner has a patient, and certainly they are not alive. So getting some clarification on that and deciding and helping the law articulate who has regulatory responsibility there. And how we would approach that. So we've been looking at that. We've had a few medical examiner issues come up over the past 5 years or so, and this is just one of those things where we've noticed that we'd like to clarify. And next slide. So that's it. If there are any questions or clarifications, we're happy to speak to those. I know that probably was a lot for 30 minutes, just throwing it all at you, but we're happy to stick around and answer whatever you need.
So I hope everyone will join me in a virtual round of applause. Thank you so much for a wonderful presentation. As Micah said, feel free to type your questions into the chat or use the raise your hand function at the top of your screen. Coffee with the Commission is a time for discussion, so please feel free to turn on your cameras, but remember to stay muted while you are speaking. So while folks organize their thoughts, let me ask a question. Within the next 12 months, are there any dates or timeframes that attendees should kind of mark on their calendar or be aware of for recently passed bills taking effect? You mentioned that, these timeframes can be based on rulemaking and other things, but just in a general, should I be paying attention to the UDA taking effect over the summer or at the end of the year?
Right. So basically, upon signature of the governor, most bills take effect within 90 days, unless they have what's called an emergency clause or if they have a delayed implementation or effective date. The bills that we're talking about, which was the clinical experience bill and then the UDA tech fix, House Bill 1640, those are 90-day bills, so they'll become effective shortly before July 1, I believe. The weekend of July 4. Is when all of those will become effective. So for the tech fix, we don't have to do anything. For the clinical experience bill, we are scrambling to do what they have asked us to do. I forgot to bring that up. So this doesn't often happen when there's ambiguity in legislative language, but in this case, it kind of broke in our favor. And they decided to include the full text of a hardship exemption. And so for the purposes of a clinical experience license, we are now empowered, once we develop the procedure internally, to consider hardship scenarios for people who would like to get a clinical experience license. So this is important for refugees, people who are persecuted in their home countries, people who come from war-torn countries, and maybe in the case right now of India or Kashmir, maybe their medical school is no longer existing. And so all those records are gone, and they don't have the ability to go through ECFMG because ECFMG needs something to work off of in order to assess whether this person is truly a physician and whether they completed their training. So that also extends into problems with being able to take the U.S. medical licensing exam. And so this hardship waiver would allow us to do two things. Number one, we've already secured from the Federation of State Medical Boards the ability to use the special purpose exam, which is a version of USMLE on a case-by-case basis. So if we have someone who cannot access the USMLE for some reason, then we can, on a case-by-case basis, use the SPECS exam. We call it SPECS, special purpose. And then we also have the ability with this law change to send people for assessment. So we, on the disciplinary side, we already use these skills assessments. So if you're, say, a general surgeon, we can send you to a specialty center who will, over the course of a week, assess you, walk you through oral presentations. You will verbally discuss case selection, patient selection. You'll do clinical labs, and it'll all be overseen by people of that same specialty. So the report that is generated by experts, and we are highly reliant on those assessments. And we, at this point, have not seen them go wrong. So the hardship pathway would be a use where we would send someone for a specialty assessment. They would take the SPECS exam, and based off of that feedback, it'll be a longer process, but based off of that feedback, we would present it to our commissioners who serve on what's called Panel L, or our licensing panel, and they would make the decision whether to issue a clinical experience license. Given that a clinical experience practitioner is already going to be supervised by a licensed physician in this state, the bar is a little bit lower. But I will point out that the hardship process does not apply to someone who can have access to ECFMG and the USMLE but can't pass. So that's a key distinction. If you have the ability to go through ECFMG and USMLE, you have to do it. This is only for folks who don't have access to it and could potentially pass it.
Circling back to Jimmy's original question just for a second. So the majority of bills would be enacted 90 days after they got signed. So that would be in the summer, unless it's written in the bill that there's a specific date. And usually when that happens, it's about a year. So those aren't always the standards, but usually it's 90 days or the bill is enacted an entire year from that time. So like I said, not always the standards. Sometimes work groups and other educational requirements get enacted throughout different dates in the year. But as a rule of thumb, people should look during the summer after legislation is enacted in the session, both short and long.
Well, I don't see any questions in the chat or any hands raised, so I want to thank you again for presenting this valuable information, and thank you everyone for attending and participating. Have a wonderful week, and remember to take care of yourselves. Thanks.
Thank you.
Have a good day.
Thank you.